Welcome, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I am Dr. Robert Feldman, and I am a neurosurgeon, which basically means that I operate on the brain, the spine, and the peripheral nerves. Today's YouTube video is going to be on lumbar degenerative disc disease, which basically means you've got a bad shock absorber in your back and you're having pain. This is a very good video to start with because a lot of the subsequent videos that are going to talk about other problems of the spine have to do with degenerative disc disease. So I would recommend listening to this video and then maybe going on to a specific video about your specific problem. The purpose of this video is to basically kind of give you some basic information so that when you land in front of your neurosurgeon, you're not so caught up in trying to understand what they're saying that you end up not listening to them. So hopefully this will be kind of a superficial review of degenerative disc disease of the lumbar spine, and I'm not going to go into crazy detail, but it will get a little detailed. This may also be good for some of you that maybe are seeing surgeons that aren't very good at explaining things to patients, even though they may be great surgeons. So let's talk about lumbar degenerative disc disease. Let's look at a model of the lumbar spine to see what a degenerative disc really is. Okay, so this is a model of the lumbar spine. These squares are the bones, and then the little stripes in between them are the discs. Don't think of the disc as this flat thing that slides in and out. Think of it like a pocket of jelly. That jelly basically acts as a shock absorber, and that jelly is kept inside this space here by a ligament that wraps around the bones. As we age, the material inside the disc changes composition, changing from one type of collagen to another type of collagen, and the ligament that wraps around the bone starts to deteriorate. It gets dehydrated and brittle, it starts to develop little fissures or cracks in them, and over time, the functional capability of that shock absorber to do its job decreases, and it just stops doing a good job as a shock absorber. As a result of that shock absorber not doing a good job, changes can occur in the spine, and your body can react to those changes in the spine to cause pain. And the most typical symptom that will occur in a patient with degenerative disc disease of the lumbar spine is low back pain. And that can be, chronic, smoldering, not too severe back pain that just kind of annoys you, or it could be drop you to your knees, you're laid up in bed for a week back pain. And typically the back pain comes from both inflammation of nerves in the disc itself, and they get irritated when the disc moves around too much. It can also come from changes that occur in the spine to compensate for that bad shock absorber that over time slowly crowds the area where the nerves are and can cause pinching of your nerves that live in that area near the disc and the joints. If that nerve gets pinched, then in addition to your back pain from your degenerative disc disease, you can get leg pain. And that can be pain, numbness, and tingling that shoots down your leg all the way into your toes. And that has another name also, which is called sciatica, which basically means leg pain. In addition to the nerves being pinched causing pain, the disc itself causing pain, there is a structure in the back of the spine where the above bone and the below bone meet called the facet joint. And it's kind of shaped like this. And if we look on the model, there's the forebone, there's the five bone, there's the disc. If we look towards the back of the spine, we can see the forebone here, and then the five bone there. And that facet joint is supposed to move just like any other joint. If this shock absorber is not doing a great job, this facet joint will be under more stress and rub around too much. The little nerves inside this facet joint can send a signal up to your brain and say, hey brain, we're upset down here, do something about it. The nerves in the disc itself can do the same thing. And your brain's going to say, hey guys, all I can do to really help you guys out down there is try and keep things more still. And the way I'm going to decrease movement around these facet joints and around this disc is by tightening up all the muscles back here without your permission. And that is called muscle spasm. So in addition to inflammation from the disc, inflammation from the facet joints, pinching of the nerves from changes occurring deep inside here, and then all the muscles that tighten up back here, all of those things combined to one degree or another is going to give you that back pain. So that is basically what a degenerated disc is, as well as why it occurs and causes pain. Okay, so you've been having back pain, maybe some leg pain. It's not going away with taking it easy or some over-the-counter medications. So you finally go to see your primary care doctor or your chiropractor, and they say, you're not getting better. We got to figure out what's going on. Typically what they're going to do is they're going to take pictures, usually X-rays, maybe a CAT scan, probably an MRI. That's going to really show us whether you have degenerative disc disease causing your back pain. So let's take a look at some X-rays, and then we'll take a look at some MRIs, and we'll talk about what does degenerative disc disease look like on an X-ray or an MRI. And hopefully when you see your neurosurgeon, they're going to actually show you your own pictures so you can actually see what your particular spine looks like. So let's look at those X-rays. You're looking at 3 pictures of a side view of the back, which are the first, the third, and the fourth pictures. This picture here, the second one from the left, is a front-back view of the lumbar spine. So if we take a look at this one on the left, again, the squares are the bones, the spaces in between them are the discs or the shock absorbers, and what you can see is that these disc space heights are fairly well maintained. These discs look pretty plump. The edges of the bone look pretty sharp and well defined. You can actually start to see a little bit of bone spur growth here. I call these the bird's beaks because they look like bird's beaks. And these are bone spurs growing on the edges of the spine, and they occur because these discs aren't perfect, but relatively speaking, these are pretty plump and healthy looking discs. As I said, this picture in the middle here is a front-back view of the spine. It's harder to see the discs unless you're looking straight on, which you are in this particular case, but because the spine naturally curves down here, it's harder to see the disc spaces. The structures to really see here that are relevant are these little hamburger bun things here and here, here and here. They're harder to see on an X-ray, but these are the facet joints. On the side view picture, the facet joints are right here. This is where the bone above meets the bone below, and this joint here can get irritated and inflamed if this shock absorber is not doing a great job, but this one looks like it is. Now if we transition over to the third picture here, we see a healthy disc between the 2 bones here. This is the L4 bone, this is the L5 bone. So this is called the L45 disc, and that looks like a pretty darn good disc. But in contrast, look at this disc here between the L5 bone and the sacral 1 bone. This is the tailbone down here. So this is known as the S1 bone. So this disc is called the L5-S1 disc, and this is a terrible looking disc. The bones are close together, practically touching. This disc has collapsed a lot. The hole right here, where the nerves come out to go down to our legs, looks pretty tight compared to the hole here and the hole here. So this is an example of what a degenerated disc looks like at L5-S1 on an X-ray. Now let's jump over to the X-ray on the far right, and this shows degenerative disc disease that has significantly progressed. The disc space is collapsed. There's even some gas inside of the disc here. Gas on an X-ray looks black like this. So air or gas will look black. And the disc, when it starts to deteriorate, can get some byproducts of gas production, and you can get these black spots in the disc. Most significantly, however, we can see that the holes for the nerves are very tight, and significant bone spurring, big bird's beaks here in the front of the spine. And again, these bone spurs are growing in response to the excessive movement that's occurring because this disc is not doing a good job. So these bones, which are living things, will respond to changes in forces and pressures, and to try and compensate for the excessive movement, these bones are trying to increase surface area And the way it does that is by growing these bone spurs. So this is a end of the spectrum extreme example of significant degenerative disc disease compared to a healthy disc all the way over here. Okay, so we looked at some X-rays. Now let's look at what an MRI looks like that shows degenerative disc disease as well as a normal MRI. So a couple of things about an MRI. The first set of pictures we're going to look at is called a sagittal image. That basically means you're looking from the side. So if this is your spine, your lumbar spine, these are the bony, pointy things that you feel running down your back. If you take this spine looking from the back and you turn it to the side like this, that's called a sagittal image on the MRI. And you'll see the squares on that MRI, which are the bones. You'll see the stripes in between them, which are the discs. You'll see these pointy things in the back, which are called the spinous processes. And then you could also see these things here, these little hamburger bun-looking things, and these are the facet joints. Again, the joint between the bone above and the bone below. So that's a sagittal image. That's what we'll talk about first on the MRI. And then there's another type of image on the MRI called an axial image. And the axial image is, instead of looking from the side, you're looking down the tube like this. Except you're not looking from the top down, you're actually looking from the bottom up. But let's pretend we're looking from the bottom up here because it actually looks the same. You'll see this circle here, which is the bone, or if you move forward or up or down, it may be the disc in that slice. This space here is where the nerves live. There's part of the facet joint, and this Y-shaped thing is the spinous process and the lamina, which is the spread out part here. The spinous process is the vertical part here. So imagine when you're looking at an axial MRI like this, as if a slice of your spine pops up like a piece of toast, and you're looking at it from below up. So because you're lying on your back in the MRI, and imagine if you stand at the foot of the table when you're lying in the MRI, and a slice of your spine pops up like a piece of toast, left and right are going to be opposite. Because when you're looking from below, the right side of the picture over here is really going to be the left side of the patient's body. So not really relevant for our YouTube video today, but just keep in mind, an axial image, you're looking down the barrel of the spine. Bone or disc, nerves, facet joints. So let's take a look at these images on an MRI. These are, again, side view or sagittal images of a lumbar spine. The picture on the left is what I would consider relatively healthy discs. The picture on the right is the beginnings of unhealthy discs. So again, if we look at this picture on the left, these squares are the bones, and the stripes in between them are the discs. On this particular MRI, which is called a T2 image, anything that's white has a lot of water in it. So if you notice, these discs have a lot of bright signal in them, and that suggests they're very cushy and spongy and hydrated. Whereas if you look on the right-sided picture, you can see that these discs look darker. There's less hydration in them. That decrease in hydration is a sign of degenerative disc disease. You can also see how this disc is starting to become less plump looking and more flat looking. And then if you look down here, you can see how the disc is actually very collapsed and practically touching. It almost looks like this number 5 bone is digging into this number 1 bone. You can see this bright color in the disc here, but this is actually more than likely inflammation or edema or swelling as opposed to a nicely hydrated disc. You can actually see some of this inflammation or fluid signal actually creeping into the bone itself, suggesting that things are rubbing around too much down here. You can even see how this number 5 bone is slipped forward compared to this number 1 bone. So the alignment of these two bones is not normal. Again, signs of a degenerated disc. You can see little bumps forming on the back of this disc, but higher up you can now see that these discs here look a little neater or sharper, but still starting to collapse. So all of these discs on this picture look like they're deteriorating. This one looks particularly painful, whereas the picture over here shows relatively healthy discs. This section here is where the nerves live. These little stringy things here are the nerves. This is the bottom of the spinal cord right here. And just as a little side note, this MRI, interestingly enough, is actually my MRI. So this explains why particular activities, especially vacuuming, laundry, and dishes, lead to a lot of backaches and pains. This is a bad-looking disc. Okay, now let's look at an axial image or down the tube image of the lumbar spine. So this is an image of the spine looking down the tube from the bottom up. And imagine a slice of the MRI or the slice of the spine popping up like a piece of toast, and we're looking at it end on. So because we're looking from the bottom up and the patient is lying on their back in the MRI machine, this side of the picture, even though it's the left side of the picture, is the right side of the body. Nevertheless, on this picture, this black circle is the disc seen end on. This triangle here is where the nerves live, and these little dots are the nerves seen in cross-section. But more importantly, these hamburger bun-looking objects are the facet joints. And this Y-shaped structure, and with the little point down here, is the spinous process, and those are the bones running down the backs of our spines. Now these facet joints right here look relatively healthy. They're kind of nice and neatly defined. The edges are nice and sharp. The fluid, which is this little white stripe in the joint, is not too big or overly developed. The ligament, which is this black stripe here and this black stripe here, is relatively thin. And these joints show evidence of relatively minimal degeneration, and that's because this shock absorber is doing a good job. If we compare that to this picture on the left, we see these facet joints look very different. They're ratty looking. They've grown these big edges back here, which are bone spurs. The fluid space is very enlarged, and the ligament here is much thicker, this black stripe. All of these changes occur slowly over time in response to the fact that this disc and this shock absorber is not doing a very good job. So these joints are under more stress and moving around too much, and to compensate for that, they try to decrease movement by growing bone spurs and thickening these ligaments. One of the downstream consequences of these changes is that these structures can grow into the spinal canal. So you can see here that all the little nerves seen in cross-section are bunched together because the space for those nerves is much less than in the healthy spine right here. So again, when these changes occur and these nerves have less room, you can eventually pinch a nerve and give you that sciatica type pain shooting down your leg, numbness, tingling, also weakness. We'll talk about pinched nerve problems and options for those in another video, but just so that you know, these changes of degeneration that occur because this disc is wearing out can eventually pinch a nerve. Okay, we talked about what degenerative disc disease is. We talked about what they look like on a picture. So you've confirmed that's what you've got. Before you consider surgery for this, what are your non-surgical options? Well, non-surgical options for lumbar degenerative disc disease and back pain is typically anything but surgery. It's a long list, and this is not all-inclusive, but generally it includes things like anti-inflammatories, that's things like Motrin, ibuprofen, Advil, Aleve, muscle relaxers, pain medication, physical therapy, heat, ice, massage, chiropractor, acupuncture, wearing a back brace, hanging upside down, traction, rubs, creams, and then injections. All of these things can help. They will help in two people with the exact same problem. Some of those things will help in one person but not another. But typically that's the kind of process of things you would do before you consider talking to a surgeon. Anti-inflammatories work because the nerves that supply the disc and the facet joints get inflamed. They tell the brain that they're upset. The brain then tightens up the muscles. If you take anti-inflammatories, particularly before you do an activity that might aggravate your degenerative disc disease, it can suppress that inflammation And the message to your brain that things are upset down there won't go to your brain, and then your brain won't tighten up those muscles. So anti-inflammatories are very effective at lowering that signal that comes from the nerves in your joints of the lumbar spine. Muscle relaxers are helpful because, again, your brain's trying to keep everything still down there because it's wiggling around too much. Those muscle relaxers will stop or prevent or break up or lessen the tightness of those muscles, which is typically a very big component of the back pain that people experience. Pain medication is pretty self-explanatory. All those things hurt, but really pain is a perception in the brain, so pain medication usually blocks those pathways or signals that take the perception of pain from the actual part of your body that hurts to the part of the brain that says, oh, this hurts. So pain medication is another good option. Downsides of the pain medication are they can be addictive, it can be hard to function on them, they can also cause constipation. Physical therapy is good for stretching and strengthening muscles, breaking up muscle spasm, teaching you the right way to bend, lift, and twist. Physical therapy is often necessary before an insurance company might approve an MRI, or certainly before approving surgery sometimes. Physical therapy can be helpful with flare-ups of back pain. It can also be helpful in helping you maintain good practices and ergonomics so that you can prevent back pain in the future with degenerative disc disease. Chiropractor, I'll often tell patients when they say, is a chiropractor good or bad, or should I see a chiropractor? I'll often say, if you just have back pain and not leg pain, which suggests it's a mechanical problem with your disc and your joints as opposed to a pinched nerve problem, I usually say, go for it, see the chiropractor. Very good for mechanical spine issues. If you've got a pinched nerve, especially if it's in the first couple weeks, I wouldn't recommend getting manipulation by someone like a chiropractor because typically your nerve needs to rest. The last thing you want to do, especially in the first couple of weeks, is irritate that nerve more with lots of movement of the spine. Typically, a chiropractor will put you through an X number of week program, no matter what your symptoms are. I'm not a big fan of that, but there are very good chiropractors that will realize you've got leg pain, you've got a pinched nerve. We have to tailor your program so that we're not manipulating you as much or in certain ways because we want that nerve to rest. So certainly a chiropractor is worth giving it a try. Acupuncture, there's no real studies that prove that physiologically works, but I have lots of patients that swear by it, so it certainly is not going to hurt, so I recommend giving that a try. And then things like creams and rubs and patches and things like that, those are good for symptomatic treatment. They can increase the blood flow to the muscles that are tight and sore. It can increase blood flow to the areas that are inflamed, and that can help wash out a lot of those toxic chemicals that build up because you're having injury or irritation to those areas. So that is the kind of least invasive list of options with conservative therapy. The next thing on the list of conservative therapies is a little bit invasive, and that is injections with pain management. Pain management physicians are usually physiotherapy or anesthesia physicians who get specially trained in managing pain. And typically for degenerative disc disease, that's going to involve injections. And injections are typically divided into two types. There's epidural steroid injections, which is basically an injection of steroids directly into the spinal canal area, around the sac that covers the nerves. Steroids are basically a super strong anti-inflammatory, and that can coat the nerves and the joints that are inflamed and suppress that inflammation. These can be very effective. They can often save you from needing surgery. But remember, the pathology that's causing all these problems doesn't change with a steroid injection. It's still going on. So oftentimes the steroid injections become less effective with time, and you may end up needing surgery. Another type of injection is called a facet block or a facet rhizotomy. If, for example, your shock absorber between 4 and 5 isn't working great, and these little joints, which are called the facet joints, are rubbing around too much and inflamed and irritated, that could be a big part of where your pain is coming from. 90% of your pain could be coming from these facet joints rubbing around, and only 10% could be coming from this disc. Well, one option for treating these facet joints that rub around is facet blocks and rhizotomies. A facet block is where a pain management physician will use X-rays to guide a little needle inside this joint. That needle is not a needle that injects medicine. It's a needle that has a radio frequency tip on it that can heat up. So they'll get that needle inside that joint, they'll turn up the needle so that the radio frequency temperature increases, they burn the little nerves inside that joint, so even if it's rubbing around, it can't tell the brain that it's upset, and in turn the brain may not tighten up those muscles. So typically you'll get some numbing injections in those joints. The pain management physician will send you home and say, come back in a week and tell me how you feel. If you come back and say, oh my God, it was fantastic, all my muscles relaxed, all this pain went away, then that pain management physician has just proved that these joints right here are the source of your pain. They would then go back in a different procedure with the radio frequency needle and burn those little nerves in there. Now, that can be a long-term fix. If you're lucky, it can last up to a year, but oftentimes it doesn't last that long. It can last weeks or months. You go back in for a second or third try, and over time they become less effective, similar to the steroid injections, and over time you might eventually need a surgery because those things stop working. But the injections with a pain management physician are kind of the last stop on the conservative therapy train, and once you've maxed out all of that, then it may be time to talk about surgery for your back pain from degenerative disc disease, and then you might be sent to someone like me to consider fixing that problem. Okay, so you've been diagnosed with degenerative disc disease, you have back pain that's interfering with your quality of life. All the conservative therapies that you've tried, including injections and physical therapy and chiropractors and medications, just isn't working. You're missing work, you can't play with your kids, you can't do the activities you like to do. You go back to your primary care doctor or your pain management doctor and you're like, listen, it's just not working, I'm miserable, what's the next step? Well, at this point, it may be appropriate to talk about surgery. And this is the point where you would be sent to see someone like me. Hopefully this video will enable you to kind of understand things, at least at the basic level, so that when you see your surgeon, you'll be able to absorb a little bit more of what they're telling you, and also maybe kind of calm any anxiety that you might have that, oh my God, I might need spine surgery. So the solution to back pain from degenerative disc disease, unfortunately, is not a small surgery. Typically, at least the surgery that I would do for this problem is called a lumbar fusion. And basically, the philosophy behind a lumbar fusion is there's your 4 or 5 disc, the disc between the 4 bone and the 5 bone. It's not working very well. The bones are rubbing around too much. You get a lot of back pain because of muscle spasm. The philosophical goal for treating that problem is you want these 2 bones to stop moving around so much. That's called a lumbar fusion. You want these 2 bones to fuse together so they don't move around anymore. So how do I do that? You're asleep, you're in the operating room, we roll you over on your belly on a special table. There's, for example, the L4 and L5 levels. I'll make an incision in the middle of the back about 3 inches long, and I'll remove these 2 bones and a little bit of the bones on the sides, exposing the spinal sac underneath them. I'll take those bones, mix them up in a special blender in the operating room, mix together with that some special stuff that makes bones grow fast, and I'll save them for later. So now I've exposed this area, the spinal sac is underneath that. I'll go in on the right and the left sides to get access to this disc from the posterior or back direction. I'll then go into this disc and I'll clean it out of all the disc material and the cartilage. I'll basically make this an empty space. While I'm in there, I'll look for any pieces of bone or ligaments that are pinching the nerves that have kind of changed over time because your disc isn't working well. I'll make sure all the nerves are unpinched. So now these bones are missing, the nerves are unpinched, I've cleaned out the disc. Now our ultimate goal is to get these 2 bones to grow together. So the next thing I'll do is I'll take something called a cage, and this is an example of a cage, These come in different sizes. This is made of a plastic type material. Here's an example of a cage made of carbon fiber. But you'll notice that these cages are hollow in the middle. And what I'll do with this is I'll take the bones that I borrowed from the back of your spine and mixed with some special stuff that makes bones grow fast, and I'll pack that into this space. And I'll do that with 2 of them. And then I will put one of these on the right and one of these on the left, and I'll tap them into this disc space. So they're kind of sitting inside like that. And because these come in different sizes, I will pick the spacer that will prop these 2 bones far enough apart so that they're about the normal height. That's good for the biomechanical functioning of the spine, but it's really good for keeping this hole big so that the nerve that comes out of this hole, the spinal nerve, is not pinched. So now, instead of bone, disc, bone, I've got bone, spacer, bone, and inside the spacer and in between the spacers is a bunch of your own bone that I borrowed from back here and some special stuff that makes bones grow fast together. And our ultimate goal is to get these 2 bones to grow together solid. That takes about a year in the lumbar spine in an average age person. A little younger, it might be quicker. A little older, it might take longer. Now, a good way to get 2 bones to grow together is to keep them still. That's why you break your arm, you break your leg. What do? They put it in a cast. The way we put the bones in a cast in the spine is with the screws and the rods. Now what I'll do is after I unpinch everything and borrow the bone from back here and put the spacers in, I'll sew you back up in the middle. And then through very small incisions, probably about less than 1/2 inch, I'll put these screws in. And nowadays most surgeons will put them in using X-ray machines or navigation type computers or even surgical robots to make sure these screws get put in the right place. You don't want the screw too high because it can bother the nerve in here. You don't want it too low because it can bother the nerve in here. You don't want it angled too far towards the middle because it can bother the nerves in here. You don't want it angled too far out here because then it's not in the bone and it's not doing anything. So these are called pedicle screws, and they basically keep these bones still so these bones grow together solid. After about a year, when the bones have grown together and you don't need those screws anymore, you don't go back in and take them out. They just kind of sit there and don't do anything after about a year. That whole surgery takes about 3.5 hours. Full disclosure, I'm not a big fan of doing lumbar fusions for degenerative disc disease, and the primary reason for that is it's typically not one disc that's causing the problem. It's many discs. And it's a big surgery to fuse 4 or 5 bones together. But the real reason I don't like to do that, even though it might make your pain feel better temporarily, is that if you fuse 2 bones together in the spine, or even 3 or even 4, those bones don't move anymore, which means the next shock absorber up is now the point of movement of the spine. So if you fuse all these bones down here together because the discs are bad and you've got back pain, then this guy right here is now the transition point, and this disc gets very upset quickly. So a year, 2 years later, you may be ending up with more back pain than you started with because that upper disc that you didn't fuse is now picking up all the slack. You go back to your doctor, the doctor says we have to extend your fusion another level. You get another surgery, you add another level onto your fusion, and now you've got one more bone that doesn't move, so the next one up is even more angry. So I'm not a big fan of doing lumbar fusions for multi-level degenerative disc disease. There are, however, some exceptions. So what are those exceptions? The primary reason I will offer a lumbar fusion for degenerative disc disease is if, number one, the patient is pretty much incapacitated with discomfort. They can't do what they need to do, and nothing else has worked. The second reason I'll often offer lumbar fusion is if there's one particular disc that is clearly the most upset. And then the third reason is if the patient is unstable, which means that at that level of bad disc, they wiggle, they move around too much. Typically, I'll prove that on an X-ray where I ask them to bend forward and bend backward, and the 2 bones slide forward and backward like this. That is a very strong suggestion that particular level is the primary reason for their back pain. And it's quite possible that if we fuse those two together, even though it puts stress on the other discs, they may be able to get away with it and never need another surgery. Or if they do need another surgery at another level, it might not be for 10 years. So that is the primary reason I'll offer a lumbar fusion on someone with just degenerative disc disease and really nothing else. Okay, so we talked about the surgery that I typically do for degenerative disc disease if the patient needs it. I'll typically tell the patient it's about 1 or 2 nights in the hospital, 2 weeks stuck in the house not doing much, and then 3 to 6 months of a slow increase in activity back to baseline. I'll recommend they wear a lumbar brace for probably about 3 months, not all the time, but just whenever standing or walking. And then I often tell patients that because this is a big surgery and there's a lot of trauma to the tissues around the spine, it can take 3 to 6 months until the patient really feels themselves. I'll also mention that typically manifests in the later months as pain at night when the patient rolls over in bed when they're half asleep. Typically that's because they're not really guarding and they just roll over, and the muscles around those screws can rub against them and hurt. So you can imagine these screws are kind of sitting in the big muscles, the strap muscles that run down the spine. It can take about 3 months or so for the body to form a capsule around these screws. And that capsule is kind of shiny and slippery. It allows the muscles to move over those screws and not hurt. So I will warn patients that they can expect 3 to 6 months until they really feel themselves again. So that's kind of the recovery of the surgery. What about the risks? Well, there are 3 risks to any surgery. It doesn't matter what kind of surgery it is. It could be an ingrown toenail surgery, could be a lumbar spine fusion surgery. Same 3 risks: infection, bleeding, problems with surgery. All relatively low, especially for this kind of surgery, but it's in the book so that we have to tell you. And those are the 3 any surgery risks that are associated with lumbar fusion. There are a couple of risks that are special to this surgery because it's surgery in the spine. One risk is injury to those nerves. We're unpinching bone spurs around the nerves. We're putting spacers near the nerves as they go into the disc. We're putting screws into the bones that are near nerves. It's quite possible that one of those parts of the surgery could go wrong and you could hurt a nerve. Typically, that's pretty rare, but it's in the book, so I have to tell you about it. And oftentimes, if the nerve is just upset or bruised, you're going to have pain, numbness, tingling, maybe even a little weakness associated with that nerve, whatever muscles that nerve controls, but typically that will get better over time. Another special risk to this surgery is something called spinal fluid leak. The covering of the nerves that wraps around the nerves in the lumbar spine not only contains the nerves, it contains spinal fluid. If you get a tear in that covering, the fluid can leak out and give you a spinal headache, which is a headache that's worse when you're standing up, better when you're lying down. Typically, if that happens, you're going to see it right away during the surgery. You put a little stitch in it, little patch on it, glue it, lots of ways to fix that. Again, very small chance, but it's in the books that I've got to tell you about it. The last special risk to a lumbar fusion is, again, you fuse these bones together, these two. That means this disc and this disc are now under more stress, and over time you may need your fusion extended up a level or down a level as those discs eventually cause you more trouble. And those are the risks to that surgery. Okay, so we went over some basic principles about degenerative disc disease of the lumbar spine. We talked about where it comes from, what it looks like on pictures, what your symptoms are when you get it, what your options are other than surgery, and then a little bit about surgery itself. Keep in mind that your surgeon may have a preference for one option versus another, when to operate, when not to operate. But this is enough of the basic material so that when you show up in your surgeon's office, you're not kind of deer in the headlights type thing. So I hope this was helpful. I hope it was easy to understand. I know there was some technical jargon in there. This is also a very good video to watch first before you watch all the other ones. I will be uploading more videos on specific topics, for example, herniated discs, spinal stenosis, spinal instability, compression fractures. We'll talk separately about the cervical spine versus the lumbar spine. And then we'll go into more neurosurgical topics, for example, about the brain, the peripheral nerves, things like that. We'll also get to the point where you guys can leave requests in the discussion below. If you want me to talk about a particular topic, I can work on a video for that. Hope you enjoyed this. Hope it was worthwhile. If you did enjoy it and if you did think it's worthwhile, please like and subscribe. This will enable me to keep putting up videos. Thanks again for visiting your go-to doc, which is me, Dr. Feldman, and I'll see you for the next one.